Good evening, all. About this third wave, this is something which I would like to start with an honest sharing that this is prediction, right? So when you are talking about future, mostly it is prediction, and worldwide, all the predictive models which had come about, especially in this COVID time, they had errors. Okay, so what you see on the right is the median absolute error of anywhere varying from 20 to 30 days based on the kind of modeling studies which looked at these predictive figures, like, when would third wave happen, how many cases would occur, etc., etc. Similarly, even when you look at the median error in terms of the bias, in terms of, when actually the timing of peak would happen, even in that you see that there is a variation of about 10 to 20 days based on different methods. Okay, so the first basic thing for all of us to understand is that whatever predictive mathematical modeling you use, whatever data input methods you use, it is very likely that you do have some significant variation, and it need not be exactly the same way as you predicted. Okay, I was surprised to find that there is in fact a journal called International Journal of Forecasting. This is PubMed indexed, so not a prank. Really, there is a journal called International Journal of Forecasting, where they had a summary about all the modeling studies done in COVID. This was updated till end of December 2020, and again with the similar thing that the forecasting is not exactly accurate. Okay, so we start on this premise. But then, does it really hurt to be prepared? Now, if you think that your forecasting or your predictions may not be right, then why should you actually spend time and effort in understanding what could come in? Okay, so preparation is important because it determines two things, right? It determines our resource allocation. That means where do you want to place your resources, where do you want to get your resources from, and also about resource diversion, right? Maybe you should do this instead of this. So this is very, very critical. Okay, this article is from Concept in Disaster Medicine, which they list down the kind of preparation which we should take so that our resource allocation, meaning how much amount of resources, manpower, machine, equipment, money, etc., we should get ready, and resource diversion. What are things which are less prioritized, and how can you prioritize things and move resources in that fashion? So definitely, though forecasting may not be accurate, we need to keep an eye on the future, because that helps us to prepare for it by in the present, right? So that is the reason why this is important. We are talking about the children and involvement of the children exactly for the same fashion, right? To see whether we need to prepare more resources in handling if we have an onslaught of sick children in our community. Now I will take you through three major publications which looked at the third waves. Okay, so this first publication. So this publication predicted the third wave to peak in the first week of September. Okay, so, and it was also supposed to extend into early mid-October. Okay, I have taken three major studies, right, which have used very standard of care modeling data, which have used recent second wave data for inputting, right? So because it's sort of would improve upon the accuracy. I have not taken older modeling studies. I have taken only the later modeling studies published this year, last 3 to 6 months, so that the second wave data is also in there. So the first study predicting that the third wave will peak sometime in the first week of September 2021, extending into October. The second one, this is a preprint version, not peer reviewed yet. This is a preprint version. It was very, very recent. This actually painted a very, very pessimistic view. So this suggests that again this is the latest. So they have used data until the April 2020. So this suggested that the present pandemic and this high numbers, okay, the high ups and downs with these peaks and surges, that itself would last in India till end of January 2023. So another 1.5 to 2 years with these peaks, and that it will continue, or the pandemic or these infections would continue to happen in India for a long number of years of 12 years. So they, in their calculation, it came up to 4,434 days for the pandemic to completely settle in India. Okay? And by settling, the definition for that is that when the number of persons spreading the infection is less than 20. Okay, so Obviously, vaccinations, etc., may change this calculation, but this was a very, very pessimistic study which predicted that for a long time India would continue to have these COVID cases. Why is this important? Is that the longer the surges and the COVID peaks persist, higher the chance that you will have mutations which will escape the present vaccination. Okay? An example is Delta, which all of us know that, right? So if India continues to have peaks and surges, we would continue to contribute vaccine resistant or immune escape mutations to the world over time. So that is why this is a very dangerous trend to have. Now, if that was a very, very pessimistic outlook, this is the other side, an extremely optimistic view. This was again published just 3 to 4 months ago. This predicted the trend looking at data from 4 major states, Maharashtra and Kerala included, which were having very, very high number of cases in this year. And as per them, because of the impact of vaccination and with the data which you are seeing, we would not have a third wave at all. Okay, so meaning, if you look at the graph, the red curve is what shows the active infected. So you see that active infected, it peaked in May to July. And after that, by September and all, it just goes down and that's it. We are not having any further peaks at all till November 2023. So this was a very optimistic view from their prediction model, suggesting that the second wave is all that we are going to have. We are not going to have further waves at all. Now, out of these 3, what do you believe? What do you take back from this presentation? So I come back to a recent publication from ICMR, again an ICMR modeling study. I am not sharing, I am not talking about their predictions, but what I am talking about is they have listed down a couple of factors which would promote the emergence of wave. Okay, so they try to postulate the theory on which waves could happen, 3rd or 4th or 5th waves could happen. So they postulated 4 reasons why surges could happen. 1, the population's immunity could wane without any change in virus, right? The antibody levels wane, the T cell immunity level wane, and you have reinfection because our population's immunity goes down over time. Okay, so that was one theory. Second is that you have an emergence of a new virus variant which can escape the pre-existing immunity. The population's immunity is intact, maybe because of prior infection, maybe because of vaccination, whatever. But however, the new variant can escape or overcome this immunity. This is very, very possible if you continue to have high transmission. Why? More the transmission opportunities, more the virus replication, more the chances that mutations will arise, and under the presence of a vaccination pressure, high chance that these mutations could be something which may overcome the available vaccines, right? The third thing is that you can have a more transmissible variant without loss of immunity to the previously circulating strains, right? The regular baseline strains, you continue to be immune, but the transmissibility of the newer strain is high. It may not be resistant, but it is more transmissible. The ICMR claim that it could be unlikely because if you want this, the R naught, okay, the number of persons which you could spread from one person should be 7, or in their calculation, anything more than 4.5 could actually trigger off a surge, right? We know that the R naught for Delta in some scenarios is as high as 7. So this is possible. You could have a highly transmissible variant of an R naught of more than 4.5. You can have fresh opportunities for transmission because we relax the local restrictive measures like lockdown. So this could result in super spreader events, right? Something like a huge conglomeration of a huge group of people getting together, and you have people who are so-called super spreaders who are very efficient transmitters, and you have hundreds and thousands of people getting the infection from the same place. We know that in India, in the present state, as of today, all these 4 factors are possible. We know that from the first infection, it's more than 9 months, 8 to 9 months now. So reinfections are possible. We know that new variants can come up. Delta had come up. We know that more transmissible variants can happen. Delta is more transmissible. And we know that super spreader events can happen. Multiple super spreader events have happened in India during this 6 to 8 months itself. So all these are possible. And hence, a third wave is definitely possible. So I go along with the theory of that a third wave is imminent towards maybe August, September, October. rather than go with the very optimistic view that waves will not happen. This is just a pictogram showing how the Delta strain changed the game. The R naught being 3 with the original strain. That means one positive patient spreading it to 3. The R naught for Delta in Sikri went up to 7. That is one COVID positive patient giving it to 7 patients in his vicinity. So when and how the third wave would behave, how high it would go, how low it would go, etc., depends on a lot of things, and primarily 3 major aspects. The slide shows a snapshot of how the peaks have been for different countries. So if you look at US, it had a low peak in July 2020 and a very high peak in Jan 2021, and then in July it's slowly peaking. Turkey 2 peaks, but if you look at France, you see that it has a steady stream of cases continuously, no significant ups and downs as for other countries. So country to country, area to area, time to time, there is variation in the peaks and surges and the lows. Why is this? It could depend on the vaccination coverage. We know that we have been rapidly progressing in this aspect. So the better the vaccine coverage, the peaks, etc., would maybe less. The arrival of new variants would change this completely, like how Delta changed it for Israel and US and even for UK to some extent. Obviously, individual behavior, that is adherence of how people and public stick to the compliance measures for COVID, including masking and social distancing, also would be a critical factor. And obviously, this would also determine the super spreader events, right? So these are the 3 things which would determine how the third wave would evolve in India. Coming back from a perspective from United States, so in this publication, it was calculated that the United States needed to administer 3 million doses of vaccine per day if they want to avoid an immune escape variant coming out from these present peaks, okay, what the US is having now. So if United States needed 3 million doses per day, just imagine a country of India's population, how much vaccine it will need if you have to prevent a peak or prevent an immune escape variants from happening during this peak. Okay, so it's almost a lost game. I don't think we can buck up our vaccination to that extent, but at least we are somehow getting there. Now, coming to the second part of the our discussion, in terms of the children, will they wear the brunt of the third wave? Okay, right. We had this theory that in the second wave, more and more younger people were affected, right? So in that fashion, there was a fear that would the third wave predominantly consist of children, because children now remain unvaccinated, because we have been vaccinating 18 plus in all countries and India also very actively. And because children are unvaccinated, would they be the primary targets of this third wave and would be having more of admission? So this is a little bit of a controversial thing. This Indian Express article, I don't subscribe to the title, but this is just a very eye-catching thing from Dr. Matthew Varghese, one of the physicians here in Kerala, saying that the next wave of COVID is hypothetical, and to say that it will affect children is more pure conjecture. So I try to look up some data regarding the second wave, and summarizing most of the world global data. This is a systematic review and meta-analysis. It sort of stated that less than 10% of the hospitalized cases in the world are children, okay, globally. And less than 5% of these hospitalized itself are critical. Okay. So globally, first, second wave, the involvement of children who required hospitalization, and out of those who required hospitalization, who required ICU care, actually were very minimal. Okay, 10% only of the hospital cases and 5% of these were only critical. Various theories have been proposed on why this is so, why children are spared from the most of the severe nature of the illness. MISC and all is an immunological phenomenon, obviously, which would be discussed by Dr. Senthil later. But from the epidemiological perspective, why children are less affected, even looking at the transmission part, even though there are multiple studies which suggest different things, most accepted and most major publications go for this, saying that the transmission is very, very less in the younger age group, especially under the age of 5. Okay? And that definitely asymptomatic transmission is likely, meaning children tend to be more asymptomatic and they could transmit this to elders or the adults in the family. Is this so? I try to look up some more evidence for this. one thing which I came across was from this article, a bit old, about last year, October 2020, which suggested some basic characters why children would be less affected, starting from the less ACE inhibit ACE receptors in their nasal epithelia, meaning that the binding itself would be less, to their differential response in their immune response itself, starting from the protective Th2 immunity to how the eosinophil functions and the interleukins react to the stimulation from the virus. Okay, so starting from the binding of the virus to how the virus triggers immunity or cytokines in our body, to how our immune system interacts with the virus, everything has some difference in children. Okay, and this difference is supposed to give them protective ability. This was in Nature a couple of months ago, where they proposed that opening up of schools may not be a bad idea, and the reasons, again, as I mentioned, looking at the previous publications in terms of transmission, etc., which I showed you. So I try to look at again a review of literature and evidence in terms of this particular aspect, like, specifically because we are many of the states are contemplated or even opened up schools, that is it safe to do so when children are unvaccinated. Okay, so this was one of the best comprehensive review which I found out. This is from the website of the Royal College of Pediatrics and Child Health, where they accumulated the evidence published as recent as 28th of July 2021. So from this, the key takeaways from it's about 40-50 pages review, the whole review. So what I take back from that review is 3 points. First, for that, the younger children are definitely less affected than older children. So under 12, the severity of illness has been much less compared to the older children above 12. Okay. The second is that more and more evidence that children have reduced susceptibility to COVID, and multiple reasons. I have already showed you in the pictogram of a couple of those reasons. Okay, so children are less likely to be affected or acquire COVID. And there are studies which looked at onward transmission. Okay, that meaning the child goes to the school, and what if he picks it up from other children or from the staff or the teachers, etc. So it found out that if the child is very young, that is less than 6 years, and then the onward transmission from these very young children could be high. That is because the adults handle them very closely, right? We hug them, kiss them, a lot of very close contact, and the continuous contact happens with very small children. So the evidence proposed that if the child who acquires COVID is less than 6 years of age, then the onward transmission could be high. But for the rest of the group, that is from 6 years to 12 years, it is actually very low. So they said that even if the child of above 12 or above 6 years, that is say 7 years, 8 years, 10 years, or even up to 12 years, even if they acquire it, for the adults to acquire it from child is actually less. So they looked at various cohorts in family transmission and found out that if the family has a child between the age of 6 and 12, the chances of adults picking it up in the cohort is actually less. Vis-a-vis somebody, if an adult has it, then multiple adults in the same home get it. Okay, so the least risk is actually for child to child. Okay, so the least risk of transmission was actually said to be from the child to child. So in the school, what we are scared about is transmission from child to child, right? Above the age of 6, primary school, secondary school. So that is actually supposed to be less, followed by child to adult. That means the chances of the child coming back to home and transmitting it to the elders or adults in the home is also supposed to be less. The highest is adult to adult, and then adult to child. So the message from this was that you have to create a bubble of vaccinated immune adults in the school setting. All the staff, teachers, and all the household members of a school going child, they should be vaccinated and they should take care vis-a-vis, and then it's actually could be safe for children to go to school. Finally, just a snapshot of the various variables in COVID transmission. This is important because we need to understand why this third wave happens in different countries, at different time frames and in different ways. Right? Some have very high peaks, where some have very too much of death, high mortality. Some don't have that much of mortality, etc. So these variables are one, the population density. It varies. We know that highly dense cities, even in India, we know that districts with high population density, states with high population density, etc., had higher number of cases. Social demography in terms of age structure, the breakup of elderly to children, mode of transport, etc. Social practices, the geography and the climate and the air quality. Even the air pollution has an impact on the cases and the surges. Pre-existing immunities due to previous exposed infections and vaccinations, etc. And finally, the genetic variables. So, putting all this together, it is perfectly understandable that different states, different cities, different countries will have different kind of surges and peaks and number of cases. Right. So, to sort of summarize, putting all this together, one, we understand and accept that predictions and modeling exercises are not absolute truths, but they are required for us to prepare for the future. The ingredients for a third wave definitely exists in India. Okay, so the ICMR paper, which has listed the potential reasons, all the 4 reasons are present in India. So definitely we could have a third wave. The few modeling studies that predict the third wave, they suggest that it could peak in September and that the waves could go on till end of 2023 in India. There is no hard data or background reasons like the immune studies which I showed you to suggest that children should be disproportionately affected in the third wave. And the seroprevalence studies in India and the basic immune studies globally also sort of support this fact. The vaccination and adherence to transmission breaking behavior will determine our fate. So how fast and how well we vaccinate and how we adhere to the COVID protocols, this would determine our fate, because high transmission rate will lead to escape mutations. That means we will have a lot of breakthrough infections even though you're vaccinated, and it could put up all of us in a soup. Thank you.
Good evening, everybody. Very warm thanks to this. Was a very nice academic feast for everybody, because everybody is scared of the third wave and the impact of third wave on the children. What impact it will make. Third wave may or may not come. Children may or may not get affected with the higher impact. But the things what we need to look is we need to have preparation. We need to get prepared for the possible third wave and the possible impact on children. So same way, even at Meenakshi Labs, we have made all the preparations regarding the dealing with this epidemic. We have RT-PCR facility at our main center. We are doing RT-PCR with real-time PCR as well as cartridge-based PCR, where we can give reports within a short duration. As well as we are doing all the inflammatory markers, not only at our central laboratory, but all these facilities available at all our centers. The centers include Karaikudi, Rajapalayam, Pudukkottai is newly started. Then we have center at Kumbakonam and Mayiladuthurai. We have one more new center which has started recently at Theni. So all these centers are equipped with all the inflammatory markers, and even the samples of RT-PCR will also be collected from all these centers and will be rapidly transported to our central laboratory, and the reports will be given in the defined time period, which is very short for us. And even we are planning to expand in the next couple of months to our other areas also for the service of the patient and to deal with this epidemic. So I'm thankful for all the both the speakers. They have shared their knowledge and they have enlightened our thoughts and our all audiences. And I'm thankful for the management for organizing such a beautiful platform for sharing the knowledge during this epidemic period. And that's all from my side. Thank you. Thank you all.
Thank you.